Hello?
Hello and good evening. Welcome to our CME for today. Irene, am I audible?
Yes, you're audible.
Good. Welcome to our today's CME. Dr. Wanga, you can hear me?
Yes, I do.
Oh, thank you very much. You're very clear today.
Thank you, sir.
We are happy to have Dr. Andrew Wanga as our speaker today. Dr. Wanga is a senior to most of us and a radiologist, a very experienced radiologist. And he decided to enter into the new business of interventional radiology. And that's why we're having him very many times these days, so that we know what is new, what can be done without the knife, with better results, less blood loss. So welcome Dr. Wanga to talk to us. He's talking about peripheral vascular disease with a particular inclination to a topic you'll discuss with us. If you have any questions, post on the chat, they'll all be answered. Welcome, Dr. Wanga, and you can take over.
Thank you, Chairman, and it's a pleasure to be here again. My name's, as you've been told, and I take pleasure in sharing the little I know, the little I learn. It may look late because I'm on the 7th floor, but I think age is not so serious an issue. What I've loved very much is to associate with the Society of Orthopedic Specialists. Indeed, I may not call them correctly. I call Association of Orthopedic Specialists, but I hope I'll be forgiven. In the next 40 minutes, I want us to take a journey through what takes us to do peripheral angioplasty and peripheral stenting. We have companies such as Medtronics who specialize in balloon angioplasty, and therefore I'm not associated with any or inclined to any My disclaimer is as such that we want to discuss the pros and cons of stenting and the plain angioplasty. You would stop me at any stage, but I notice here questions are written down and shall ask at the end. Indeed, peripheral artery disease is a broad subject which we may not be able to finish today. I want to get, yeah, I hope I'm able to, yeah, now I'm safe. Yeah, the most important indicators for us to do peripheral intervention is to improve circulation to the extremity. And this is an area where ortho specialists find very, very good help when the blood reaches the toes. And indeed, we need to start a little higher up. Why I start a little higher up is because when you talk about autoiliac junction, we are discussing peripheral blood supply. The autoiliac aspect is an inflow. And when you go below the inguinal, before the inguinal arteries, we're talking of the outflow. So I'll not discuss the abdominal aorta as such. That's why I brought 2 points at the front. One is to say what sort of intervention we do. You've heard of kissing stents, and these ones can be given through endovascular way, through stenting without open surgery, as long as we have a normal native artery to go through. The types given, we shall discuss again, but the most important point is to see that the autoiliac flow is an inflow and the femoral arterial flow is an outflow. Why do we need to do this? You find, colleagues, that arterial disease is setting pace among our people because of our lifestyle. I guess the people who walk a lot may not have it. The diet also, diabetes, the cholesterol levels, atherosclerosis, and when you're having lesions in the limbs, lesions in the pelvic iliac vessels and the lesion in the aorta, you see that's an extension of the cardiovascular event. So the study of this subject is so important because much as it may look peripheral, it draws blood in an area where we can get ischemic stroke or any other type of stroke or cardiovascular failure because of deposits of cholesterol throughout the blood system. So we need to have expert people. And the vascular approach, when done properly, it saves people with the chronic critical limb ischemia. In our discussion, let's just look at the limb ischemia. In case this fails, as you know, there'll be surgical bypass. And if it fails completely, you'll get either debridement or limited amputation or even above knee amputation, colleagues. Usually the results in this particular case depend on the intervention and how it's been planned. It's from the literature we note that limb salvage and control of pain and infection are key when we're trying to look at the study of angioplasty and the study of peripheral stent. A meta-analysis of the results of randomized trial, various treatments of below-knee vessels showed no significant difference in limb salvage rates and hence recommended treatment with the plain balloon angioplasty. Why am I saying this is because there are others who are actually preferring putting stents, others prefer drug-eluting balloons angioplasty. So we shall discuss that a little later. Then when there's good circulation, you'll realize that the patient has better pain control. Patient is able to move and improve his own blood supply. There are other international studies which we shall not go through when we talk of drug-coated balloon and plain balloon angioplasties. So as we move on to define critical limb ischemia, I want to say there's a difference between acute limb ischemia and chronic limb ischemia. Now, I've said chronic critical limb ischemia. This is an exacerbation of an ongoing disease process, which we shall discuss, but given the slide which is before us, you see that patients may develop resistance to pain-killing remedies, medical treatment. And when you're talking about Rutherford classification 4 or 5 and 6, we're looking at where a patient is not able to tolerate pain even if it's given opioids. And 5 and 6, where there's a risk of tissue loss. And when we're talking about tissue loss, then we enter the field of trauma specialists, because orthopedic specialists want to limit this, because if it continued, the patient may suffer from either disseminated intravascular coagulation, DIC, or even suffer from infection. So surgery at that stage of Rutherford classification 5 and 6 is key. So there's something about angiobrachial index or pressure. When we are discussing critical pressures, you find that popliteal pressure below 50 millimeters of mercury and ankle pressure below 20 millimeters of mercury is critical and requires intervention at whatever stage. So when a patient has got less than 70 millimeters of mercury pressure, we start thinking about what are we doing? There's also that concept of an angiobrachial index, but I should not go into it at this stage. I've said when I started that there are two components. One is atherosclerosis, another is arteriosclerosis. Diabetes mellitus tends to create a situation where the 3 layers of the arterial blood flow are affected, and usually the medium size to small size. Medium size are such that the femoral arteries, small size are like the popliteal trifurcation. And you find that they tend to lose their targo, and the turgidity is due to infiltration and ulceration. And then there's what one would expect as dry ischemia. But if it gets, say, a plaque and blocks a supply area, then it gives us a blue toe, and the blue toe will be an acute phase in a chronic disease. Peripheral sensory neuropathy, that's not within the sphere I'm going to discuss, but otherwise, just think of syringomyelia, which leads to narrowness of the spinal canal. Think of vitamin B12 deficiency, and it also causes severe pain in the lower limbs. Nerve root compression, thrombocytis obliteratum, which is a vasculitis. These are all cases which, when not sorted out, one would think they are due to a chronic they lead to chronic limb ischemic events. I will not discuss the venous today. I want to show you an image, and what you see here is a balloon, and also there's a level of described of exaggerated intimal thickening. This basically is a cholesterol or an area where there's poor atherosclerotic change. And atherosclerotic changes, they begin fresh, subacute, and chronic. When they are chronic, they form the plaque. This one looks fresh. What happens if someone puts the balloon? The idea is to create a lumen that is going to be sustained. Unfortunately, it's a destructive process because one has to crack the intima and the media. So you don't know whether you are actually going to get a good stay or there'll be stenosis. And it's at this stage when the drug-coated balloons, sometimes they use paclitaxel, but unfortunately paclitaxel has been noted to lead to other complications, which cannot be discussed now, but just remember it's a chemotherapeutic drug that leads to bone marrow depression and can cause myelogenous crisis. So after balloon dilatation, then we fit a stent, the image you see below. The stent here, this is a diagram, it's not a real life situation, is more smooth than we expect. And you also see they are square, so this one is a fenestrated. You can also have coated stents or covered stents. The lower limb, in real life, you'll find that the areas of plaques, narrowness, and almost near occlusion. And it occurs at the femoral popliteal junction, what we call adductor hiatus, about 6 centimeters above the knee in a normal adult. So to be able to cross this area, sometimes one requires to have access, which I'll discuss towards the end. Suffice to say, the changes you see to your left are indicating a progressive disease, which starts with a small lacerated plaque. And this accumulation of the small clots, and then they form a big ulcer, and then the ulcer has to be broken. And when you break the ulcer, that's the time you find that you are crushing both the media and the intima, and the serosa is one that's left on. So it's better to have a stent in place. Infrapopliteal, below knee stents are good, but they require expertise. I want to show you something which was not basically my interest, because I'm trying to look at the incidents where the trauma surgeons come in handy, because at this stage we need a cardiovascular surgeon or interventional radiologist to go and get what is blocking the artery that's crossing the blue toe or the blue foot. You can see the right foot is cyanosed. The left one looks a bit better. And this is a presentation typically in diabetic patients because they're not walking up and down because of severe pain, ulceration, and all of a sudden you get this sort of change. It can be due to a clot, can be due to a plaque, it can also be due to infection because there's poor clearing of the supply of blood in this place. And that's why they talk of the veins being empty. But this is an acute phase. I'll go to show you an algorithm on how to deal with it. Before you do that, this image came in between. These are the common cases you get of obstruction at the autoiliac junction. These are the major vessels that are affected by atherosclerotic change. I'm keen to show you that you can see a measuring device beside, and this is an old-fashioned, old way of doing these things. These days, the equipment is got automatic measurement calibration, but this is how we started. And this one, you don't need kissing stents. You just give one side after you do the angioplasty, but it gives you an indicator on where medicine has grown from and where we are. You can also see right lumbar artery forming snake-like or convoluted anastomotic collaterals, which gives supply to the hip region arteries, and that keeps the lower limb alive. This, unfortunately, should have come before the other image. I want us to remember the indicators, even if you're on phone, on a patient who has established diabetic foot, who has established a problem in due to limb ischemia, who has been on conservative treatment. We talk of the pain symptoms being intolerable. And if you look at that leg, the doctor will tell you it's pale and the pulse is not felt and of short duration. Paresthesia is abnormal sensation and paralysis does occur. Actually, basically it's weakness because the nerve supply is not sufficiently perfused. So when you compare the right and the left, you see the left looks quite healthy and the right side appears more cyanosed, and there are areas which show you a bit of mottling. So this is what I was telling you about assessment and deciding who is to play which role in acute limb ischemia. We have talked about the 3 signs: pain, paleness, paresthesia, weaknesses or paralysis, and absent pulses. So this is a patient that requires quick action. You can start with the intravenous heparin and do the imaging correctly. Then stage 1, if the limb is viable, there's no need for treatment. And stage 2B, if you find that the limb is threatened, then you need to do thrombolytic therapy or atherectomy to remove whatever is causing obstruction. Stage 3, you'll see that there's irreversible damage, and that one, the earlier we get orthopedic intervention, the better. So the most important take-home message in this slide is, do we have a viable limb? Is it at risk of continuous ischemia? Is it an issue where we need to involve other colleagues so that we inform them in good time, prepare them in good time, to be able to have what we call minimum amputation or distal amputation? So when you're treating patients, and especially in chronic critical limb ischemia, it's key to assess what am I dealing with. If it's a atheromatous plaques and the rest of it, it's easy to break and do angioplasty and stent. If it is due to diabetic arteriosclerosis, we recommend just drug-eluting balloon angioplasty, because these vessels appear to be constricted in a matter to say shriveled. And when a vessel is not having good lumen where the catheter will pass, microcatheter will pass, then you find that you need a lot more expertise than you have locally. Indeed, you can do even crural approach or the foot arterial approach using ultrasound and continue to open up the vessels of the lower limb or the below knee. But key is that we must have one vessel which is patent. I told you about the events in angioplasty. We need to see here in number A, where you're passing your balloon angioplasty catheter. It's not yet ballooned, and this is an exaggerated form, usually they're thinner than this. Then 2, you are actually breaking the atheromatous plaque, and this one is being done below bifurcation. It's not good to work across bifurcation because it may cause occlusion to branch artery. Now, once you finish and there's good flow, you don't forget that the serosa is still holding the muscular layer, muscularis mucosa, the circular ones, and then the intima. So it could come and close. So there must be good perfusion and continuous medical treatment. We give Plavix, which is clopidogrel, and also Ascard. Can be given singly or give double, but you give double, it doesn't make much sense. I think after 3 months, 1 month, you give 1. This sort of thing, I just approached here, I'm wondering whether could this be the Lerishia syndrome or not? You can see distal aortic occlusion. This is the kind of changes you expect in fibromuscular dysplasia. Maybe it not be very clear where you're sitting, but look at the beaded appearance of the left external iliac artery and down to the femoral, so that you appreciate such a patient's fibromuscular dysplasia are not good for standing because you'll get post-stent constriction. These ones may benefit from surgical bypass. Pathophysiology of critical limb ischemia. It's a worldwide problem, and usually America comes up with her figures. 10 million was in 2017. Maybe now it's big or no. But what about we in Kenya? It's high time we started looking at our category, whether we're going to go to the Fontaine classification or go by the Rutherford-Becker classification to have a stratification of our cases, because above 40 years, the limb ischemic changes are quite real. Though we recover, but some people already have wrist pain, diabetic complication, the trauma, and all this. So the disease is important, and it's also the, as I said before, a contemporary or it's a accompaniment of coronary artery disease. So peripheral arterial disease patients are at risk of myocardial infarction as well as stroke. The risk factors are the same. Hypertension must be controlled, diabetes should be controlled, age cannot be controlled, but I think if you live what we call health adults, not working from home, But I'm told with the COVID, you need to work from home above the age of 60. Chronic kidney disease, hyperlipidemia. I don't know about the male gender, but colleagues, you've done trauma and you've examined men more than me. You'll tell me why the male gender should be there. Diabetes mellitus, obesity for sure, indeed. It causes major problems and creates bad health for many people. So we need to be physically active. This is a runoff which we can share, but what is important to me to say is the orthopedic specialist has no time to find out what risk factors should have been done, because by the time we hand a patient to you, he's already at the rate of either rehabilitative treatment or therapeutic. So I think that we need to look at this as cases. If managed, they'll come to you cleaner than they normally do. Bluto, I've already covered it, where you get some thromboembolic from something. For example, if one has got atrial fibrillations, you can throw a clot in the toes, but that is more cardiovascular and endovascular specialists to deal with. Leriche syndrome, occlusion of infrarenal abdominal aorta, and both common iliac arteries. It manifests as a triad of pain, impotence, and absence of diminished femoral pulse. This is for interest, because in trauma, indeed, you'll hardly come across it, but your patient could have it in the beginning cases before it gets complicated and comes to you. Fibromuscular dysplasia, I've already shown you an image, and these are some of the things which made me feel it's important to share, because FMD can cause dissection, distal embolism, and it causes because of poor flow of blood across it, since it already causes intermittent obstruction and occlusion. So what can we do? In endovascular management of patients, we believe in first-line clinical treatment, which if it fails, then we can go in to be able to restore circulation by means of image-guided percutaneous transarterial engagement. So before we do that, we discuss with the cardiovascular specialist surgeon to see, do you need to do surgery on this? No. But if the area of occlusion is very long, bypass graft replacement of the vessels, either using a vein or any other material, which may be external allografts, is important. But basically, let us not reach that stage if our endovascular specialists are keen and willing to work. So I've talked to you about this, and I'm going to show you a few of them. What's important is to be able to do a safe study. Safe study means, for instance, if I want to dilate a vessel and achieve a level of 6 millimeters, then my balloon angioplasty should go to 7 millimeters. If I want 5, I should be oversized by about 1 millimeter. And you get some cases where you just want the lumen to be open and you put 4 millimeters, for example, when there's chronic obstruction, because once the blood reaches the foot, the toe arteries, then there's good perfusion, and that's enough for the trauma specialist to do that. Covered stents are okay, but at junction points, unfortunately, they can cause blockage and critical branch ischemia. Then drug-eluting balloons, as I've told you, use paclitaxel, and one company in Kenya which does have these facilities, Medtronic. So I repeat this for the sake of our sharing this session, but key to say is that the Fontaine category is usually 1, 2, A and B. Rutherford are usually 1, 2, 3 up to 6, the categories. So they just intertwine. For example, if I was talking about Fontaine 2B, I'm talking about a very severe case. If I'm talking about the Rutherford 4, that's when you find patients not cooperating with the medicine. Rutherford 1 and 2, it does not require any treatment because the limb is viable and just a question of lifestyle change. The bypass is on the same note. I've talked about we need to take care of when to refer patients to our colleagues. Also expect the colleagues to be honest enough to know and share with us their patients. And the technology we have, many young men are now doing this work, not I alone. So the key point is best practice. Best practice cannot be overemphasized. So this is a busy slide, which I can move on. I'm just showing you the principle of doing the balloon. Is it destructive? Or is it just something which you do without causing damage to the vessels? Definitely, it's for a good reason. This was a research done on swine. And so the systematic way of doing this work is as shown. When you deploy the stent, it will expand, and the self-expanding stents fit in certain areas, but in lower extremity, I would rather balloon expand it so that you have a specific size. But when you are in the aorta, you try to do the self-expanding stents. Now, drug-eluting and bare metal, the difference is that with a stent which has got drug embedded in its fenestrations, in its web, tends to work better, but for only 6 months. After 6 months, they become the same. So once you can have bare metal and give supplements which antiplatelets, including Ascard or junior aspirin, 300 milligrams loading, and then 175 daily for 3 months, 6 months, or for life. Then Plavix, I think, is given a little shorter in most centers, including the UK. But there are also contraindications, some of them not so absolute, but we shall run through them. Uncorrectable coagulopathy, severe renal failure, the filtration is less than 30, the normal is about 60. So we find that we need to ensure that we are giving a patient adequate hydration before procedure, during procedure, and after procedure. We're giving the correct medication, and the load of contrast media is nephrotoxic, including MRI contrasts, which can lead to nephrogenic fibrosis. So it's key to ensure that you take care of these patients before the procedure. After the procedure, it may be too late. So, non-ambulatory critically ill patient with limited life expectation, don't just do a case for the sake of it. It's important to have good result, a good outcome. And unfavorable anatomy, these ones can go to the details later on. It's interesting because they're very important. And also we need a good runoff to the lower limbs up to the foot, because if you don't have a good runoff, then you're not going to help the other arteries you are opening. Pressure hemodynamics, we could go into those. So it's also good to know what we do. If I want to work on superficial femoral artery on the right, I cannot go antegrade. I'll have to go over the bifurcation. And sometimes the bifurcation may be so acute, then I could do radial approach. But radial approach, you need a long catheter, but you lose pressure. And if I want to go to the popliteal region and have a good native artery, I would rather go at the femoral. I do a high femoral puncture, a common iliac artery, a common femoral artery. And then you go and have sufficient pressure and you can go up the ankle and do your work there. So the site of entry depends on what we expect. And post-procedure management, I'm thinking about putting pressure or using closure devices. These are some things you can go into if you are quite keen. As I've said, dual antiplatelet therapy is good, but lifelong, no. I think Ascard is sufficient. As you know, it can also cause problems, patients who have at risk of bleeding ulcers, duodenal ulcers. No, risk first modification is important. The people stopped smoking and they're doing pretty fine. Then there are no standard guidelines. That's why we need to follow patients up and have our own records. This is a case which, as you see in A, had a total occlusion. Some of these cases here locally are due to HIV/AIDS, and it was easy to dilate and do angioplasty and retain good circulation. So these are some of the things I found exciting when I was working both in Nairobi Hospital and Kenyatta. Apparently, outside in the private sector, it's ability dependent. I'm not saying Nairobi Hospital is public, but I think that the funding. This is atherosclerotic, showing high occlusion, 3D reconstruction, which we do pulmonary angiogram. When you do CT arteriography, or rather, when you do CT angiogram, pulmonary angiogram, there's one challenge that you lose your ability to do proper catheterization. So it's also good to have after CT angio to learn how to do digital subtraction angiography, because in intervention, that's what you're going to depend on. These arrows show us areas of frequent interruption. When I talked about adductor hiatus, you can see on this other slide, if my pointer shows there, that's where the femoral artery is cut off from the popliteal origin. This is a very good thing. There you put a stent, and below the popliteal region, this they don't put stent because you'll fracture, but there are stents which are now pliable, they're not a problem. I'm going towards the end of our presentation. Let's look at the possibility of there being complications. Yes, if the puncture is too high, you can have retroperitoneal hemorrhage and can be life-threatening. If you end at an aneurysmal area, also you have a challenge. If you use closer devices at puncture site and you don't know how they work, you may kill a patient with exsanguination. That's why it's important to have post-operative follow-up by the players the same day and have clear instructions to the nursing team, hoping they're dedicated. Distal embolization can be done by aspiration thrombectomy, thrombolysis, or using the Fogarty balloon. But now there are many more modern balloons. So aspiration is performed so that we don't lose that limb. And should we get in trouble, my dear colleagues, ortho specialists, you are there. So loss of pulse, you go back and check. This is a busy slide, but it's very interesting. It has two categories. If you look at the center of these circles, it's one diagnosis: chronic critical limb ischemia. And you check on the slide B and find yourselves, where are you? At the top, we have vascular interventionist or surgeon. In A, they're talking of endovascularization. This appears to be more modern. Then you come across an area where they're talking about orthopedic. I don't know whether you've seen it. You go, this plastic surgery, orthopedics, and then the other side, they call it minor or major amputation. I don't think that's your job. Your job is to enjoy seeing good vascularization. The take-home message in this slide to me is to re-emphasize the fact that we as colleagues must form a team, and everybody should watch the timelines. The point to earn by watching timelines to have favorable outcome. So the social worker, care managers, plastic surgeons, or the wound care specialists, these are people when must be coordinated by one center. And without that coordination, we run in trouble. To continue to conclude, colleagues, I've said quite a bit, I've given a lot of my work, but I think that's not key. What it is here is education. Have we done it? Yes. Have we done it properly? Yes. Have we managed complications? Well, yes and no. That is the key, to be able to manage the complication and give us good outcome. So we should do proper patient choice, making sure that the imaging and correct diagnosis done, multidisciplinary team, physicians, ortho specialists, ensure pre, intra, postoperative procedure, and hospital management staff. So I want to end and thank you and receive any questions. Thank you, colleagues.
Thank you very much, Dr. Wanga, for your presentation. It's very interesting to us as surgeons. I've seen several questions on the chat. Dr. Wanga, is the chat available to you?
The chart, let me see. Okay, let me, I'll check. Oh, charts, yes, wait, sir, I'll get, yes, I'm saying, yes. From Edward, what's the smallest vessel to stent would consistence of atheroma affect decision of stenting? Now, I hope that's the one, Chairman.
Yes.
From Edward. Yeah, thank you. Now, if I'm allowed to respond,
yes,
I would say this. Expertise determines how far we go. The smallest vessel for me to put a stent would be the popliteal trifurcation, that is the tibialis anterior, perennial, and usually perennial is the workhorse of the foot. So if you can keep those ones open and tibialis posterior, actually anterior is not so much. I would go for posterior and perennial. But I've seen in literature, and especially the modern people doing endovascular studies dedicated to the foot, they stent even the dorsalis pedis. But for us here in Nairobi, it doesn't pay much because our cases either come late or we have catheters which would burst those arteries rather than even help us to create good access. But microcatheters are expensive, but they are good. Now, estimated cost of the procedure, atheroma does affect, but what stage are we discussing? Because what we are interested is lifestyle change, and cholesterol diseases can be managed. And there are statins, psilocybin, whatever it is, a tongue twister. So I'm looking at chronic atheromatous changes, which are already formed ulcerated plaques, which we must deal with. And so those ones will not affect stenting, but there's something called in-stent growth. If you're using fenestrated stents or bare metal stents, but if you use coated stents, then there's no problem in growth, but there can be overgrowth at the other ends. So yes, you do the stenting when you have them and choose wisely which type of stents you're going to use. What about, Edward, a good question? The cost of the procedure, it's nerve-wracking because here we are underpaid. I saw in a study which is quoted, a study which is quoted in America, where stenting or balloon angioplasty has been charged 3,200 32,000 US dollars. That's already 3.2 million Kenya shillings. Let's not go that direction. Let us look at solutions. We have stents made in our friends' country, India, and they're made under license and they work. Two, let's ask what the patient or the country can afford. Personally, if I did this professionally, I would not stent anybody at more than 80,000 Kenya shillings. That works about 750 US dollars. That's my labor. And I would expect the stent cost not to be more than 100. So with the 300,000, we should be able to do a lot of work. It is just angioplasty. Angioplasty depends on the balloon. So we need to talk to the market partners to reduce their costs. But it will depend from hospital to hospital. And I'm aware cardiologists do stenting upwards of 250,000 in a missionary hospital to 1 million in up market. So that market is a bit complicated. How does angiobrachial index help in decision making of stenting? I think it helps us to classify the prognostic indicators. For example, when the ratio is 1.3, there's a different connotation compared to when the ratio is 0.4, where the ankle blood pressure is higher than the brachial blood pressure. But what I like is to talk about 50 millimeters and 20 millimeters in the ankle region. That one helps us better in patient selection. So when the patient have been selected, then you ask, which artery am I dealing with? If it's a medium-sized artery and you don't have experience to go to the small arteries, just do angioplasty. And if you can't do balloon angioplasty and you have drug-eluting, drug-coated balloon angioplasty, that's even better. So angibrachial index is key in every patient. Someone wants to Rutherford the classification. I said there's class 1, category 0. That's normal. Class 1, category 1. That's okay. There's rest pain, but not limiting. And that does not require treatment by drugs. It requires exercise and moderating if you're a smoker to stop smoking, and they do well. Now, when you have class 2 and 3, this was medical treatment. But when you have category 4, where the medical treatment has failed, then that's the time we consider doing endovascular treatment and angioplasty. 5 and 6, that's tissue loss. Tissue loss is like Fontaine class 2B. So that one you must, of necessity, subject the patient to ortho specialists for debridement or limited amputation. Steve Ogendo, thank you. Conventional surgical training on vascular surgery towards endovascular surgery. Is it a myth that endovascular procedure costs more than the traditional method? Yes and no. I think we have a wide players. As we speak now, the cost of a vascular specialist should not exceed 100,000. Why should it go up? Because when you look at the person paying you, or even the insurance, oh no, the Kenyan market should be more humble than what I see today. I'm not talking against my colleagues, Dr. Mugambi or whoever it is, but the hospitals have run wild because they take it as an opportunity. And the only way you can make a subject popular is to control the cost and teach well. To be able to get trainers, let's not play politics, but I leave it at that, Steve. I'm sure that I talk a lot to colleagues, both in Kampala, here and in the region. Unfortunately, when you are a straightforward player, you may hurt people who want to play on costs. So in some cases, because like now, you want to do transjugular intrahepatic systemic shunt, a surgeon will go and see what he can do, resection, whatever it is, but it's a good study, but they put the consumable at 700,000 Kenya shillings. Even if I charge you 100,000, it doesn't make sense. So we need also to find out, how do we get our supplies? Okay, Barry. Thank you for your appreciation. And if I've forgotten something, anything, please, may I hear through a chair, because I'm going to join your team as an associate. Already I'm an associate member of the Cardiovascular Society. Thank you, Chair. Are we there? Am I being heard?
Yes, you are being heard.
Thank you, sir.
How many stents can you put at a go?
Oh, yes. Well, when you have interrupted stenosis, like femoral artery, they call them cascade stents. You start with a bigger one and then put a slightly smaller one. That means you start up and the smaller ones go down. The reason they do that is because one has to stay in the other so that there's a tight fit. Now, this cascade stents are good because a patient gets good flow. But recommendation, long stenosis, if the outcome is going to be temporary, then let us do either angioplasty with the drug-coated balloons. A long balloon of 20 centimeters can be obtained, or we subject to graft bypass. But as I said, the best thing, you can do cascade and a very long distance and you come away with it.
Okay, I've seen that you've said something about patients with poor renal function, where the GFR of less than 30.
Yes.
Even when they are undergoing dialysis, you do not want to do
Indeed, by the way,
Stenting?
we can use carbon dioxide. I don't know how that will be found. It must be cheaper than oxygen at the moment. And it's a good contrast agent, by the way, for patients with renal failure. And it's an area which we need to adopt in this country because carbon dioxide is available as a very good contrast agent. Now, about dialysis, yes, look at the justification. When a patient is going to lose his limb because you don't know where the clot is, it doesn't matter whether the kidneys are functioning or not. So what we recommend is do undialyze. But the point is, at 30 mils per minute is a bit too low. We raise it to about 60 or 80, and it does work. Renal physicians now and nephrologists are quite keen. So I don't see it as an absolute contraindication. It's something correctable, sir.
Now, you've given us a list of risk factors.
Yes.
For patients who are asymptomatic, is there any screening program or we just wait for them until they start complaining?
Yeah, the screening program is key because we need like someone who has rest pain, that's serious because we need to screen them and find out what's happening. And that's where good ultrasonography is important, angiobrachial index is important, Doppler ultrasound are important, and also there's something called plethysmography. I think it has something to do with blood pressure measurements. So it's actually non-invasive. Screening is non-invasive, and cost containment is very, very good. What is required is dedication to train in the techniques of ultrasound and observations, and also physicians to give us good education, including the social workers.
Thank you. I've seen a a comment by Stephen Ogendo.
Yes.
And I think Dr. Wanga tried to answer it. Change in practice usually comes from teaching and from learning. Those of us who are in practice, if you are not attending any CME, you will not know that we have moved from opening to interventional radiology. So those are the things that will make us change. Two, the other thing is accept and what we used to do. And then we call the ones who are doing the newer thing to do it on our patients with better results. It reminds me of what was happening between TURP and open prostatectomy. Most of those who wanted to do open prostatectomy, they don't even have the patients. The patients are running away. They're telling them, but I heard there is a new way where you don't even cut me and I go home tomorrow and I don't have to carry a catheter for 2 weeks. Let's tell patients there are new ways of doing things. And of course, for us as doctors, let's also keep the costs at minimum. The only headache is that doctors don't own hospitals. So when the patients come to hospital, the other side decides how much the hospital will charge. And sometimes it's the cost on the hospital, the cost by the hospital is so high that the patients may not afford, but we don't have a place where we can take them where it's cheaper, then headache comes. There's a concept that took people to India, and that is affordability. And when operations are affordable, the surgeons and the practitioners become so good, such that they can do many within a limited time, and the results are very good. When the price is very high, then we do very few, and we never become very good. It will be very good to balance the two so that we have some income, yes, but we are also doing many. Yes, Wanga.
Chairman, I want to combine that with two good questions by Professor Gendo and Devlak, our colleague. First and foremost, we worked on vascular procedures, learning both from surgeons and gynecologists and vascular. But I don't know whether it's true today because in the year 2000, when I went to Karachi hands-on, South Africa, 2 years later, I was just observing. Then I discovered that India and Eastern countries trained us hands-on and better. As you put correctly, we should look for cheaper ways. And then when I was in Kenyatta, the highest I charged for private procedure was 30,000, and I managed to survive. what we need to do is to pick a cue from what the chairman rightly says, let's do many at an affordable price. 2, let's not put patients' lives at risk, proper investigation. 3, destroy the myths, which Professor Gendo has correctly said, that interventional radiology is more expensive than open surgical treatment. And it's true for many reasons. 1, if you do it badly, the patient may die. If it doesn't die, we'll have to go for open surgery. 2, we know that people, the tree falls where it lives. Interventional radiology do not have their own patients. They have to get the common market pool. So some of it can be contested, but that's not my idea. My idea is to popularize this through teaching. For instance, if I was to be given an opportunity, I would teach in Maseno free of charge as long as they can pay my fee. After all, most of the time I'm just in my office. I do 1 or 2 procedures a day, or sometimes 1 in 2 days. So I'm quite happy that this country should emphasize education, emphasize cost containment, and ensure that service is rendered. Now that answers the professor's question. A C-arm can do a lot of work, especially the peripheral. When it comes to cerebral work, please don't try. We've had people amputate arteries and aneurysms, and the patients actually we lose them. So with the neuro, we need proper software, proper setup, and that one is understood. But a C-arm, be it non-vascular or vascular interventions, periphery, there is more than adequate. We may not have image acquisition, but if you explain to the patient, you want you to be okay, I'll stop there. What about compression bandages? Compression bandages are given as an alternative to patients with varicose ulcers and veins, but that topic I can pick it next time because it's a very, very important topic. So the compression bandages are good, but basically for venous insufficiency. Okay. Coronary angioplasty and peripheral angioplasty, the difference, 1 is the catheters, 2, it is the approach, because coronary, you are very close to Purkinje fibers and bundle of his. So one has to be very meticulous in handling those small coronary arteries, and they are frail. It's just like doing a neuro intervention. Otherwise, they are pretty similar. The principle is the same. Peripheral, the biggest problem is we sometimes push the clot or the plaque to the toes and we go home after ironing, which is criminal. So I think that peripheral, you can plan and get better results. Coronary also you can plan and get better results. In fact, peripheral is more time consuming than coronary. I hope Dr. Devlak have answered your question.
Good. I'm not seeing any other question on the chat. I take this opportunity to thank Dr. Wanga for agreeing to be our guest tonight and giving us a very stimulating talk, a new talk. Of course, as KOA, we want to hear what is being done everywhere by latest this morning so that we are also able to understand where the rest of the world is. I thank everybody for attending. I've seen the attendance has been very good. We were at 45, 49. That's a very good attendance. And we appreciate everyone. Thank you very much and have a good night.
Thank you all colleagues. Thank you again.
Thank you.